Welcome everyone to today's speaker series session. My name is Lale Welsh. I'm the CEO of NDF. Most of you I've had the pleasure of meeting. Today we're going to be talking to Patrick Tierney about our GNEM specific clinics that we are obviously in discussions with at UC Irvine, which will be starting soon. Patrick Tierney is a MPT, physical therapist at UC Irvine. So when that clinic starts, he's going to be the person that you'll be dealing with. So that's very good. Since graduating from PT school at Western University of Health Sciences in 1999, he's worked exclusively at UC Irvine for the past 20 years or so. So I won't keep this discussion any longer, and I'll let Patrick introduce himself and highlight some of the things he wants you to know. Please feel free to post your questions on the chat box so that we can address them with him afterwards. And I know we'll have a very interesting talk from Patrick, and we're all hoping to learn something new. Patrick?
All right, good morning, everybody. Again, I'm Patrick Tierney, a physical therapist, and thank you to Lale for that introduction and inviting me to share some of my knowledge here about GNE myopathy and some neuromuscular conditions. Just to give you a little bit more of a background about me, again, I've been a therapist for 20 years here at UCI, and my skills have kind of evolved that put me to a position that I can work with such a, a special group of people with neuromuscular conditions. Neuromuscular conditions are very rare, so you're not going to see many physical therapists that know a lot about them and how to work with patients with these conditions. So what brought me here to as a physical therapist in neuromuscular medicine is my background is working as an acute rehab therapist for the first 3 years, where I worked primarily with people with strokes, traumatic brain injuries, spinal cord injuries, multiple trauma, joint replacements, and such. Those types of patients, when they've got these conditions, it affects all parts of their life, and much the same with neuromuscular conditions. But with this group of people, they're able to progress through their conditions in order for them to be a little bit more independent. And then in 2003, I switched over to the outpatient clinic where I work primarily with, your general outpatient orthopedic issues, spine, backs, hips, knees, ankles, fractures, post-op. And that's where I also work 80% of the time, and 20% of the time I'm here in the neuromuscular clinic. And so because of my background, my deep background with rehab, in 2007, Dr. Mosafar invited me to help him out with his clinic with mostly neuromuscular and ALS clients. And so I've been doing that for 13 years. And then as his clinic grew, he has many research studies going on, which needs physical therapies input to run some of the tests. So that's where my background has grown even more with people with neuromuscular conditions. So I've been involved with research studies for people with Pompe's disease, inclusion body myositis, GNE myopathy, which that was with Ultragenyx 5 years ago, spinal muscular atrophy, and the current study that I'm helping with is people with Charcot-Marie tooth. So that's my background. So we will move on here. So basically, just to start off, I don't have any financial relationship with NDF. And today I'll present how physical therapy assists in optimizing function and prescribing exercise in people with GNE myopathy. Okay. So my goals here are to convey the expectations of physical therapy and to convey the role of physical therapy in people with GNE myopathy. Now, even though I'll have my presentation talking about GNE myopathy, it is so rare that I've only seen, just to kind of give you a background, maybe 10 people with GNE myopathy. You can see from this slide, it's about 1 in a million. So does that make me an expert in GNE myopathy? I guess relatively you can say it is, because there's probably 50 physical therapists in our department here at UCI, and I'm probably the only one that either knows what it is or has actually seen someone with it. So if I don't see that many people, how do I know how to work and treat them? Well, I'll be talking in general terms about neuromuscular conditions, and I've seen thousands and thousands of people here in the clinic that have things such as Charcot-Marie, myotonic dystrophy, Becker's, ALS, PLS, IBM. So I take the concepts of a neuromuscular condition, which it's a progressive disease, that I've learned from all my patients and still apply it to GNE. And we'll talk about that as I go through the presentation today. So another thing that comes up is, I guess, physical therapy and occupational therapy. I guess that's something I can address at this point. I am obviously a physical therapist, and we'll talk about the physical therapist point of view, but there is some overlap with occupational therapy too. Here in our interdisciplinary clinics, we run them on Tuesdays, and there's a physical therapist on board, there's a social worker on board, a speech therapist, respiratory therapist, a member from the ALS Association, and a member from the MDA Association. And together as a team, we help provide care for people. Well, we don't have an OT in the clinic, but I help screen for the OT needs. So if we want to break it down, physical therapists, just kind of think of from the waist down. This is very general. We're going to work on, check the strength in your legs. So we're working on legs for strength. We're looking at your balance if you're falling. We're looking at your walking if you need any assistive devices. Whereas the occupational therapists kind of take more of the upper body and self-care activity. Now, when you think of the word occupational, most people think about work, right? Employment. Does not pertain to that. It pertains to what activities occupy you during your day. So that could be getting dressed, taking a shower, using the toilet, brushing your teeth, your grooming, managing your kitchen activities. So that's kind of how we separate the PT and OT. So if a patient comes to me in the clinic and they've got issues with getting in and out of the shower, on and off the toilet, I can give them some feedback on that. But if it goes beyond my scope of care, then I'll refer them to the occupational therapist. And the occupational therapists are also hand specialists. So if patients have issues with their hands, fine motor, contractures, I'll also refer them to the occupational therapist, and they can work with them on the hands. All right. So as far as physical therapy, if you didn't see this slide and I were to tell you, when you think of physical therapy, what are the first things that come to your mind? And these are some often ones that you'll probably think about. Well, the physical therapists help with exercise, true. You know, strengthening, stretching, cardio. If you've got a walking issue, maybe you had a knee replacement or sprained your ankle or broke your leg, the therapist can teach you how to walk again. Balance issues, again, if you're falling and tripping, or vertigo issues or vestibular issues, balance is one of the treatments that we'll provide. You might think of modalities. You know, therapists use hot packs and cold packs, electrical stimulation, ultrasound to help with pain. Massage is another thing. That's part of our treatment, but we are not massage therapists, just to put that out there. Or maybe you might think of a diagnosis. You might have a friend that's had some physical therapy in the past because if they strained their back or pulled their muscle or rolled their ankle, or maybe they had surgery and they just needed some post-op rehab. So those are the things that you might think about when physical therapy is mentioned. So when I see patients in my outpatient setting, or even if I were to see them in inpatient, and we see them for the first time and do an evaluation, one of the things that we ask them is, what is your goal? What is it that you want the physical therapist to help you with? What is it that you want to improve during your time in physical therapy? And the reason why we ask that is because we want to get a sense of what it is that the patient wants. And in the end, that's what's important, is what it is that what your needs are. And then it also helps the physical therapist develop a treatment plan to get to that point, okay? And so these might be some of the common goals that you'll have patients say to us, and that's, you know, they want to improve their strength, their flexibility, they want to work on their balance, maybe they've got, you know, some pain issues and they want the physical therapist to help them with the pain management, or maybe they just need some help with being a little bit more independent with, you know, their walking, transfers, getting out of bed, maybe stair climbing. All right. So I'm going to go through a couple scenarios that are very common And and this kind of is setting up the whole thing about the expectations of physical therapy and the role of physical therapy, as I stated my goals at the beginning. So the first scenario goes something like this. All right, I have a patient that comes to me and let's say they have a knee replacement, and they've gone through all of their education about what to expect with their knee replacement with the surgeon and what their outcome should be at the end. And so I do my evaluation. We find that the knee is stiff, we find it's weak, obvious, and then they're walking with the walker, and the goal is for them, they want to be able to walk better and get off the walker. So we go through our 10 to 12 visits, 2 to 3 months of physical therapy. We get that knee stretched out, we get the quads and the hips stronger, we help them go from their walker to their cane to nothing, so eventually that they're out walking and pretty much doing their activities as they were doing before. So that's a positive outcome in terms of the goal was set by the patient. They would want to be able to walk at the end, and the therapist saw that and got them to that point. All right, that's kind of your standard run of physical therapy if you're dealing with someone with a stroke, spinal cord injury, a neck strain, an ankle sprain, that we're going to take them through a rehab process so that at some point they get better than where they started from. All right, that's scenario number one. And that's what usually goes through most people's minds when it comes to physical therapy. They're going to get better at the end, right? Now here's scenario number two. You've got a neuromuscular condition, all right? So you've got weakness that's going to progress over time. Now, when I asked earlier on that slide about what you associate with physical therapy, you associate with maybe getting better, getting stronger, being able to walk, having better balance. The physical therapist thinks the same thing too, because us physical therapists are trained to get patients better. All right. My first 13 years here at UCI, or 8 years at UCI, that's what I was trained. That's what I did. All my patients got better. That's what my mind was wired to do. And then I come along to a neuromuscular clinic where we've got patients that have a progressive disease. So the second scenario goes that a patient comes in and they've got drop foot, let's say, and we see that commonly in the GNE myopathy. We might see that in ALS. Eventually with IBM, some people get that. Charcot-Marie Tooth gets some drop foot. And so the patient comes in and tells the therapist, I'm really weak down here in my shin muscle and I can't get my foot up and I keep tripping, and I want to get that stronger so I can walk better and be like I was before. Physical therapist does their exam, notices you're right, that is weak. So let's go and take you through a bunch of exercises that we're going to do to help improve the strength and get you walking better. So you go through your therapy, you go through your 8, 10, 12 visits, you do the exercises, you're compliant with them, the therapist is trying all different things, and you're not getting better. And you keep tripping, and maybe you're even getting worse, or your muscles are more sore and it's harder for you to walk around because you're doing all these exercises. And at the end, you're frustrated because you didn't get better, because you had in your mind that's what physical therapists do, and the physical therapist that you saw is also trained to get you better. And so there might be some frustration at the end because that goal is not met. So that's not the fault of the physical therapist. I have to back them up too, because again, these conditions that we see are very rare. So that's where I kind of take my experience working with all my neuromuscular patients and coming up with these, I guess, precautions to help our patients along. So the expectation of the therapist and the patient at that point was not, I guess you could say, realistic to have a positive outcome. So does that mean physical therapy doesn't work because they didn't get you better? No, and it took me a good year to finally figure out what my role was as a physical therapist when I was working with people with neuromuscular problems. I couldn't take what was in my mind from all that experience to get patients better and bring that into a neuromuscular setting. It doesn't work. What works is, and into the core as physical therapists and occupational therapists, what our role is, and I had to really break this down fundamentally, is to make people as functional as possible with what it is that they have, okay? If there's not the point for them to get stronger, I can't get them off of a walker to a cane to nothing if I'm dealing with a progressive disease. Now that seems very simple, right? Of course, it's very obvious, but you know, in our minds, the conventional wisdom is that if your muscles are getting weaker, exercise, they'll get stronger, it will get better. Unfortunately, it doesn't work that way. So again, fundamentally to the core, the physical therapists and the OTs are to make you as functional as possible with it, whatever it is that you have. And that's what I'll talk about from this point on. What it is that can we do to keep you functional, all right? So exercise. That's probably the number one question or conversation that I have in the clinic with all my patients, all right? So we'll talk about exercise here. Now, exercise is needed in all of our body systems to perform to their optimum levels. There's multiple body systems, obviously your muscles, that's probably number one when you think of exercise to get them stronger. Skeletal, that's going to be your bones. You know, we need exercise resistance and gravity to keep our bones strong. Cardiac, we need exercise to keep the heart muscle strong to pump blood throughout our body. Nervous, or your nerves, you know, if you don't use it, you'll lose it type thing. So exercise helps stimulate those neurons and those connections to our muscles. Respiratory, our lungs, need to keep and open up those lungs. Deep breathing, that helps with the oxygen exchange into our blood system to get that to our muscles are working. Our digestive system definitely needs mobility to help move things through our gut. And endocrine, which is your hormones. Integumentary, that's your skin. If you ever had this cast on your foot or arm before and you take that off and you find out your skin is all scaly, it's because it didn't move. So you weren't getting that nutrition there to the skin. And also importance of mobility in more of our patients that are bed bound, right? You get the often bed sores if you're not moving around. And then our immune system too. So what are the benefits of exercise? Obviously strengthening, flexibility, and contracture control. So your contractures are when your joints get kind of curled up and stuck in a position. You often see those in the fingers. You can see them in the elbows, and you can see them in the ankles and knees. And then pain control, circulation and edema management. If we're not moving as much as we'd like to, you can have often edema present into the ankles, into the fingers and hands. Digestion is important too. Back in my days working in the hospital, for our patients that have been in bed for a long time, and we sit them to the edge of the bed, one or two things happen. They either burp or pass gas. You need to be upright and moving and need gravity to help with the digestion and push things around. And also exercise helps with the overall, feeling of well-being that you're doing something for your health. And for me, this is the most important part, taking care of the mental health. If you can take care of the mental health, everything else should follow into place. So in the GNE population, this is often the weakness pattern that we're going to see, where you're going to often drop foot is one of the first signs, the weakness of the anterior tib muscle there. The hamstrings, which are going to be the muscles behind your thighs, those help bend your knees. Your hip adductors, those are the ones that pull your knees together. The hamstrings and hip abductors help control your pelvis. So you might have some instability with your walking. Sometimes you have weakness in the hip flexors, and that's the ability to lift your leg up in the air like marching. And then moving on to the arms, it's your triceps. So being able to move your arm away or pushing can be weakened, and then your finger flexors. All right. What's interesting about this condition is it's quad sparing. Even though I have it under weakness pattern, quad sparing means your quads are intact. So I guess that's something that we still don't understand why that happens. Why are the other muscles affected, but your quads still remain relatively strong? Okay. And when you see this weakness pattern here, this is where it's really important to, if it's possible, to join an interdisciplinary clinic, or at least have a physical therapist that's somewhat knowledgeable about, I guess, neuromuscular conditions is because each of these conditions have their own patterns, and we can identify that quite, if Dr. Mosafar sees a patient and says, okay, Patrick, I need you to go see this person, they've got GNE myopathy, boom, I'm already going to I'm thinking about, drop foot. Let me go take a look at that, and hamstrings. If I have someone with inclusion body myositis and the doctor says, go see him, I've seen so many of them, I know that their quads are going to be weak. I know their finger flexors are going to be weak. So that's important if you're able to find physical therapists or OTs that are in this setting, because we're familiar with the weakness patterns of the patients, and in the end, what it is that they really need. We kind of have a head start on other physical therapists that may not know. So exercise. What do we know about exercise in the neuromuscular population? Not a whole lot. Unfortunately, just because the conditions are so rare and you don't have that many patients to sample from, it's hard to find a good, strong research study that concludes what is good and what is not. But across the board, this is not just for GNE myopathy, this is just for all neuromuscular conditions. And this is what I educate my patients with, is that the research is inconclusive. That high intensity exercise is not good, but mild intensity is. So I guess that could be a relative term, and that's something we can discuss more specifically in the clinic. What is high intensity and what is low intensity? But the mild intensity is good on muscles that have anti-gravity strength, which means if I lift my arm, I'm lifting it all the way up against gravity. So I'm relatively strong there. If I can't lift that arm past here, I don't have enough strength against the gravity to lift it up. So I'm not going to be doing a whole lot of resistance exercises on that body part that can't lift up. So the idea is that, in order to, in normal muscles, to get them stronger, what you actually do is you physically have to break the muscle down. You actually have to take it to the point of failure. So if I were to do bicep curls and I got a 10-pound weight, I would take and do, my 2 sets, 3 sets of 10. And if I get to that point where I just can't lift that last one and drop it, I'm getting to that point where I'm actually physically breaking the muscle fibers. And what the body does in response, if it gets enough of that stimulation, is makes the muscle stronger. Okay? It's very much the same as if you were to, let's say, work in the garden, or you're in your garage working with tools, and you get blisters on your hand, right? And the skin breaks and it pops. But you keep on working with those tools, and eventually what's going to happen to that skin? It thickens, right? It gets stronger. It's the same thing with your muscles in the normal setting. You have to break it down to get it stronger. All right. And then the idea with, we don't want to do that, obviously, with people with neuromuscular conditions where their muscles are already compromised. We don't want to get to that point where we break those muscle fibers, because depending on your condition, that may not heal, and now you're kind of left with more weakness. All right. So how much exercise can you do, or what should you do? The idea with the exercise, again, this is very general, is that it can be frustrating when you're doing an exercise program and you don't see that you're getting better, right? You're like, well, I'm doing all these exercises and I'm just not getting stronger. Well, your mind is thinking that you've got normal muscles, right? So that's why you're not getting stronger, is because you've got a neuromuscular condition. So what you got to think, and it's very hard, is that if you don't do any exercises, I'm going to get my hand here, this is just what's going to happen with your function. You're going to move along, and then you've got a steeper decline in your function. All right, that's if you don't do any exercises. If you do some level of exercises that your muscles can take, then you flatten out that decline. So you stay functional for a longer period of time. In both cases, yes, you are declining, but you're declining at a slower rate if you're doing some level of strengthening exercises. So yes, you're getting worse, and that's where the frustration comes in. But I try and tell my patients, think that what you're doing is holding on to your function for a longer period of time. All right. So what are some of the precautions when you've got a neuromuscular condition when it comes to exercise. You want to avoid fatigue, and fatigue is not necessarily the breathing part, it's the muscle part, okay? That you always want to leave a little, I say, gas in the tank. You don't want to get to that point where it's now just too heavy to lift that weight. So the last rep that you do should feel pretty close to the first rep that you do, all right? Don't get to the point of fatigue. You want to also avoid muscle soreness. So if your muscles are sore for, more than 2 days after doing the exercises, that might have been a little bit too much, all right? And this is the main thing I tell my patients when it comes to their strengthening exercises, is that after you do them, you should not have any difficulty with your functional activities like standing, getting out of a chair, walking, using your arms to maybe comb your hair. I'm going to give you a couple examples of some patients that I had who did some exercise and what their reaction was, all right? And this was a patient I just saw here in the clinic. He had inclusion body myositis, and I just saw him about a month ago. And he must be in his 50s or 60s. And he's walking with a walker, and he uses, I believe, like a scooter for longer distances. So he had come to me about, I would say about 5 or 6 months ago, and he just really wanted to exercise. He says, Pat, I'm not moving around. I'm just in the chair all the time. I can barely walk. I just want to do something. So I had recommended an exercise pedaler. And I don't know if you've seen, they go on the floor, and it's just a pedal motion, just like you're on a stationary bike. So I asked him, I said, try that. You'll be sitting in a chair, and you're just moving your legs. So I saw him about a month ago, and he said, Pat, I got that pedaler. He goes, but after using it, I was, in his quote terms, trashed for 4 days, meaning I couldn't walk, I couldn't stand, I couldn't get out of my chair. And I said, well, how long did you do the pedaler for? He goes, 5 minutes. That's not very long, and there was no resistance on it, but for him, that was too much. So most of us should be able to do 5 minutes on a pedaler and have absolutely no problem with fatigue or muscle soreness. But that's what it is that you want to look out for on any type of exercise that you do, that you don't have this trashed feeling or this inability to do your functional activities afterwards. And then another example of this, and this was maybe close to 10 years ago, I had a young man probably in his 30s with a form of muscular dystrophy, and he came walking into the clinic, and he just had a little bit limp in his gait. You couldn't tell too much that he had something going on, but he wanted to get stronger. And I told him about, again, the precautions for exercises, did his evaluation, and I said, okay. And I thought I was going conservative with this young man. So let's do these 3 exercises. And I had him do tippy toes or heel raises. I had him do squats, and then bending over and touching his toes. 10 reps for each of those exercises. That's it. He comes back to me the following week, and I said, how did you feel after doing those exercises? And he goes, I was sore for 4 days. All right. Again, that was too much for him. So those are great examples of what it's like when you do too much exercise, and those are real life examples from patients on what they felt after doing too much exercise. All right. So here are some guidelines. In the case of my 2 patients that I just mentioned, what you can do here is modify the reps, the sets, the resistance, or the frequency to avoid the fatigue. So for the first guy with IBM and the exercise pedaler, I had actually told him to drop it down to 1 minute. That's it. And then have 2 days of rest and see how your muscles feel. And if there was no soreness, then to do it again until he can find that point where he can do the exercise without any muscle soreness. So he would increase maybe by 30 seconds or a minute each time if he didn't have any muscle soreness. Frequency, so that'd be like, how many times a week do you do the exercises? You can adjust that. Usually with strengthening exercises, I ask my patients to at least wait 2 days in between to give your muscles enough time to recover. You can modify resistance. If you're doing a 3-pound weight and that starts causing muscle soreness, maybe you drop it to 1 pound. Sets, instead of 3 sets of 10, do you do 2 sets or 1 set? And there's obviously repetitions too. So moving on up, I'll work from down to up for these guidelines. If you've got weak muscles, so like anti-gravity, you can't lift your limb up against gravity, then you probably want to focus mostly on stretching and passive range of motion. Stretching just to kind of keep the joints mobile. It helps with comfort and circulation too. Especially like our patients with ALS, their rotator cuffs can get weak, and so you can get frozen shoulder. That's painful and that's tight, so stretching it helps with that. Passive range of motion, you would need someone to help you with that. So active is me lifting it myself. Passive would be someone lifting it for you. Since you don't have the strength to lift it, someone else would help lift it for you to do the range of motion to keep that mobility. The muscles are not working in this way when we're doing passive. So you're not going to damage anything. It's just to keep them flexible and the joints moving. Unaffected muscles, it's okay to do strengthening. Now with our different neuromuscular conditions, again, we have different weakness patterns. So our people with GNE myopathy, they've got pretty good quads. So I don't have a problem with patients doing resistance exercises, but they're not going to be able to do resistance exercises on their hamstrings because those are the weaker parts. All right, so that concludes the exercise portion of the talk, and now I'll move on to the equipment. Now, there's a broad spectrum of functional abilities with our patients with neuromuscular conditions. So I'm just covering the entire gamut of the equipment that's available that can help you, but you may or may not need this. So I'm not saying that every patient here that's watching is going to need this equipment. It's just to cover the people that may need it and just inform the others that may not. So walking devices, again, when the patients come into clinic, I always evaluate if they're able to, they're walking. I'm always asking if they've had any falls recently. If falls indicate that something is happening, especially the frequency of the falls are occurring. So while I do my gait evaluation, if there's anything that I see, I might recommend a cane, a walker, or AFO, especially for our GNE population, with the drop foot as being a predominant weakness. The ankle foot orthosis is something that's indicated. And so I wanted to make a comment about the AFO because I just learned this about a week ago. Now, I not learned it, but it just helped remind me that it'd be a good talking point for today on really how important it is to, with these rare neuromuscular conditions, if you're able to find an interdisciplinary clinic or a therapist that's well versed in dealing with these conditions. Because I had a young lady that came in with GNE myopathy with her drop foot, and she was prescribed 2 different types of AFOs, and both of them were wrong. Neither of them helped her. One was completely overkill, and she's got good quads, and that AFO that they gave her inhibited her from using her quadriceps, which were strong. So she couldn't walk uphill. Any incline, she couldn't walk uphill with these braces because they were, I guess, too strong or too good. She wasn't as weak as those braces had indicated. And then she had another brace that was just too small. So, there in the clinic, I had to educate her on what it is that she needed. So you have to take into account not just the weakness in the ankle, but the whole weakness pattern within the body also determines what type of AFO to get. So I was able to help her, guide her to get her a more appropriate AFO to make her functional there. And then we kind of move on towards, power scooters and power wheelchairs. In our ALS population, we don't recommend the power scooters. We recommend more of the power wheelchairs, just because the condition can decline a little bit faster than some of the other neuromuscular conditions. Power scooters are not adaptable, meaning when you're dealing with a neuromuscular condition and you have a regression in your function over time, the power scooter is as it is. There's no way that you can modify it to make it more usable for you. So sometimes our patients get power scooters, and then about a year or 2 later, they can't use it because maybe their hands got weaker or their trunk got weaker and they couldn't balance. Power wheelchairs, the ones that we get for our neuromuscular patients, are what we call modular. meaning that we can add components to the chair over time as the patient's condition kind of progresses. And these custom wheelchairs require a formal PT evaluation. And usually you're looking about 3 months to process to obtain. So if you're in this category of looking at power equipment, just know, like with Medicare, they consider these two to be in the same category of a power equipment. This one here, the power scooter, is going to run about $1,500 to $2,000. If you get this one with all the bells and whistles, you're looking at $25,000. So if you use Medicare to pay for this one, the scooter at $1,500, they will not provide another power device for you at least until 5 years expires. All right. So you may be stuck with this one when in the end you might need this power wheelchair. So the therapists here in the clinic, we help you guide you through that process to make sure that you obtain the correct equipment. And then these are just some miscellaneous items. Lift chairs are people with IBM, inclusion body myositis, with your quads being weak. It's very hard to get out of low surfaces, so lift chairs help you with that. It helps also with our ALS clients, and then hospital beds, obviously. And then if you require a full lift, then a Hoyer lift is indicated. And these are the items that we can help you with here in the clinic. So that basically concludes my talk right there. And so I just wanted to say that, that PTs, in the end, I guess we're used to maximize your function, right? We can't necessarily improve it, but we can, with what you have, maximize your function through activity modification, through the use of assistive devices like canes and walkers and AFOs, and then also providing appropriate exercise prescription. And then also, the PT is successful when the expectations from both the patient, family, and therapist are understood from both sides. So hopefully this information that I've given you kind of gives you another tool, and it also gives you a little bit more power to help educate therapists that you might come across with that maybe not have the background that I do, the expertise to be able to manage neuromuscular conditions. But if you can, the physical therapist should be able to take on that new knowledge if you're able to educate them on what those expectations should be with the exercise, and with you to be able to get around better, to provide the appropriate care for you. So
thank you so much, Patrick. What a wonderful presentation. I learned so much, and I know that we have on this call people with obviously affected by GNE myopathy, but also other neuromuscular diseases. So I think it was a very nice, broad explanation of what people can do. So thank you for that. Truth be told, how many people, you can tell me later, took a deep breath when he said, the respiratory part. With regards to the mental health reference that you made, I think that that's obviously an enormous help in any condition. And just as a reminder, we do have the portion of our GNEM specific clinics already open to emotional well-being. So if you are interested in having a free session with Dr. Gail Bard, if you haven't already, please contact us at info@curehibm.org, and we can set that up for you. I have a question before we launch into the questions that people are already putting in the chat box, and that is what I get a question a lot as we talk about these clinics. People want to know the difference between physical therapy and occupational therapy. You made a reference to, occupational therapy as well. Could you, for the rest of our sake, is it important for someone to see an occupational therapist and a physical therapist? And can you explain why?
So I guess you can have, there's an overlap between the PT and the OT. And we found out here in our clinic that the physical therapist, just having a physical therapist seems to be sufficient, because we can still identify what those needs are. From what I've seen, most of the needs from our patients are, the walking and the balance. the equipment prescription, which, you know, I think 80% of that can be handled by a physical therapist. For all my patients that come in here, how many percentage of them am I referring to OT? Maybe
Yeah.
like 10, maybe 10% of them. So not that many. So yes, it's still important to have OT involved in your care, but I think the majority for me, maybe it's just because I'm skewed as a physical therapist, comes from the physical therapy standpoint. If a patient is having issues with like toileting, which is usually the OT realm, I can still,
Yeah.
and I'm very comfortable in giving patients the right type of advice on what type of toilets to get, to modify toilets, how to modify showers, you know, shower benches, tub transfer benches. That's the OT realm, but us PTs come across that all the time too when we work in the hospital. So where I use the OTs mostly is coming down to splints, the hands. Okay? If they're having issues with contractures or droppy wrists that they need more support, that's where most of my referrals to OT is going to be for the hand issues. But the functional gross motor stuff, the PTs can handle that part.
I see. So OT, toileting falls under OT, and I understand a little bit now. We had a very nice presentation about these kinds of things by our certified patient advocates last weekend, a couple of weeks prior to that, with Tara Vogel, Amy Curran, Imad Kazim, and others, Mangesh. If for those of you who want to drill down further in that, there are videos in our video library at curehibm.org. You can go and see. The questions are coming in privately on the chat box, so I'm going to read them to you. Again, if you have questions, please feel free to share them either privately with us if you don't want your name mentioned, or to the entire group. I have a question here. It says, with regard, she says, somebody says, I think that ligaments behind my knees are overstretched. There is not a natural bend to my knees. Is there an exercise in particular to heal these ligaments?
Unfortunately, if it's a ligament problem, ligaments don't have a blood supply to them. So if you don't have a blood supply, you're not going to have healing. So if you look in the place of, you know, just like the sports industry, if someone tears an ACL, then they need to have reconstruction of that ligament. So if you've got a ligament problem, if you can't have surgery.
I see. So are there any, okay, so I guess I'll save my question for the end, but Tara Vogel has a question here. Says, can you tell us what exercise we can do to strengthen our hip flexors?
So depending on what level you're at, you can be sitting in a chair and do marching. So raising your thigh up towards the ceiling. If I back up, if you do it from a standing position, it's raising it up this way. That's your hip flexor. Okay. So again, if you've got full anti-gravity strength, you can do it from a standing position if you don't feel like you're going to fall. So that's going to be the most aggressive, followed by doing it in a sitting position because you're still doing against gravity. So marching. If you can't lift it against gravity, then you want to lie on your back and do something called a heel slide, where you slide your heel and bend your knee up and down. So your leg is supported by the bed and you don't have to fight gravity as much.
And doing these exercises doesn't take away from anything if you're hanging on to something, if you need to, right? If you can lift yourself up and you have your quadriceps are spared in GNE myopathy, if you are able to raise your leg and you're hanging on to something, it won't take away from that exercise in any way, right?
Not at all. Safety first. We don't want you falling.
Right.
So if you've got to hold on to something, then by all means, hold on and then isolate that hip flexor.
So then for particular questions with our disease, for people who have, there obviously because it's progressive, there's a variety of people at different places within that journey. For a newly diagnosed patient with you call it drop foot, we've always heard foot drop, so drop foot. If they're at that stage, I know you discussed it, but are there any particular tips for people to at least stay at the same level and prevent the disease from progressing further instead of looking towards making it stop. I think you've done a good job of managing our expectations that to just prevent, to slow down the progression. What tips in specifically for that can you give people to strengthen maybe their ankle or their wherever that's coming from?
So I would evaluate the other parts of the ankle. For the most part, you're going to have 4 muscles that surround the ankle. One that points your toes down. Your foot drop is the one that points your toes up. And then there's also the muscles that turn your foot inward or outward. So I would evaluate the other 3 to see how strong they are. And if they've got relatively good strength, where I feel like they could benefit from some resistance exercise, I would start strengthening the other parts of the body that are still strong to help support the muscle that's not. Unfortunately, there's not a substitute for the foot drop for the muscle that brings it up. So if we need just to put, you saw the picture of the AFO, right? And that seems to be a little bit big and cumbersome. So I understand the mental aspect of the patients having to use equipment. So I'll go for I call it a go-between. All right. If you're really flopping that foot down and dropping, but you really don't want to use this AFO yet, then use up a lace-up ankle brace. That's what I call a good go-between. All right.
That doesn't make the ankle lazy, because I've heard that. I've heard people go, oh, it'll make it lazy, and I want to avoid using any assistive devices as long as I can. What advice do you give to someone who says that?
If you're falling and tripping and spraining your ankle all the time, you need to wear a brace.
Okay.
All right, because now you're sacrificing your safety because you want this ankle to come back or get better. And so if you want to go that route and you stumble and fall and break your hip, was that a good trade-off? Right. So we always take kind of that safety part in mind. If you're able to manage that drop foot and not fall, then I can understand not going with the brace, but I'd have to look at the safety part to see if there's a history of falling or injury.
Yeah, thank you for that. Catherine is asking a question. I have GNEM and am mobile with the help of AFOs. Exercise on a low level often results in fatigue and pain a day or so after, which you addressed in your talk, for several days, she says, especially in hip flexors and shoulders. How little exercise is too little? And I think that's a great question. How do I tell when I've passed my threshold of fatigue and pain and it doesn't set in until afterwards? So how do you know when to do that? Is that something she would need to discuss with you on a one-on-one basis, or is there a general rule of thumb answer for that?
It's trial and error is what it is. So you really have to be cognizant of what exercises you're doing, how many reps, how many sets, and what resistance, what position you're in. You can write it down if you can't remember them all, and then really monitor your body for the next 24 to 48 hours. And if you're really sore after those, then go back to what it is that you did and modify that. Drop down the sets, drop down the reps, drop down the frequency until you can find that level where you're not going to have that residual fatigue and pain. And then sorry.
I just wanted to address her question about, how little is too little, how little exercise is too little.
How?
In other words, if everybody, if she just does the one rotation of her foot and it hurts, is she to do no exercise?
Then you move on to passive.
Okay.
So that's where someone else is moving that ankle for her, because if it's causing too much pain for her to engage those muscles, then we need to shut the muscle off, but still maintain the flexibility and the circulation in that joint by doing it passively now.
I see. So that's when a caregiver would hold her foot and rotate it for her.
Exactly. So that's the point now where you're moving from active to passive. All right. So when we think, just to clarify, exercise is not always active, meaning you're doing it, whether it's against gravity or with weight. If that's not something possible, then we change the type of exercise to passive.
Right. And how much pain is too much pain? I mean, to be honest with you, every time I exercise, I'm sore for a couple of days. Is that always a bad thing, or is it just because you're talking to a subset of people with muscle weakness? I mean, how much pain is okay?
Usually, I mean, just as a general, even with all my even orthopedic issues and stuff, I try and not drive the pain if you use an analog scale between 1 and 10, 1 being very little, 10 being severe, nothing above a 5. That's usually my rule of thumb. Try and keep it under that 5. And again, you also want to fall back on your function. If you have soreness and you can't get out of a chair, you can't get out of bed or climb the stairs or walk, that's the other thing that you're also looking at, okay? Because in the end, that's what's the most important, is the function. If functionally you can still do all those things and you keep your pain a little below a 5, you're okay. But if you functionally can't do those activities because of the exercise, then you're not doing yourself any service.
Well, I think that's an important distinction. Thank you for clarifying that. So some pain is okay and actually just a sign that you've done good exercise, but too much pain where it keeps you from doing what you need to do, that's when you know you've gone too far. So I hope that has addressed your question, and Catherine. And so let's see, I think we are out of questions unless anybody else has one. But I just wanted to really, really thank you so much for this very informative talk. We will obviously have this recording up and in our video library very soon, and Rachel will let everyone know when that's ready. Thank you again, Patrick. We look forward to seeing you again, and hopefully maybe even do a presentation for caregivers to do passive exercising with their patients. So thank you so much. As always, we really appreciate your participation in the live broadcast so that you can ask your questions, and we look forward to seeing you next week. Thank you, Patrick.
All right. Thank you, everybody. Have a good day.
Take care. Bye-bye.